All right, let's dive in. Dizziness. It's one of the most common reasons a patient will come see you. But for a lot of us in training, it's also one of the most terrifying, right? It's this super vague symptom that could mean anything from a totally harmless inner ear thing to a massive life-threatening stroke. So how do you sort through all that? How do you figure out what's going on? Well, that is exactly what we are going to break down today. So picture this. You're in the clinic, or maybe the ER. A patient looks at you and says, "Doc, I'm dizzy." And just like that, your list of possible diagnoses is a mile long. It can feel, well, pretty overwhelming. But the good news is there's a systematic way to approach this, a framework that can bring a whole lot of clarity right from the get-go. And here's our game plan. We're going to start with the problem itself, what to do with that vague complaint. Then we'll get into defining what the patient is actually feeling. After that, we hit the most critical fork in the road, telling the difference between central and peripheral vertigo. We'll show you some key exam maneuvers you can do right at the bedside. And finally, we'll build some mental models for the most common vertigo syndromes you're going to see. Okay, first things first. We have to decode what dizzy even means. Because let's be real, dizziness isn't a diagnosis. It's just the start of the puzzle. So here's your very first move, and it's absolutely crucial. You have to ask the patient to describe what they're feeling without using the word dizzy. Just take it off the table. Ask them, tell me what it feels like. Does it feel like the room is spinning around you? Or do you feel like you're about to faint? Maybe you just feel unsteady on your feet. Seriously, this one question is probably the most powerful diagnostic tool you have right at the beginning. Once you get them talking, once you get that real description, you can start sorting. And your job is to figure out which of 4 main categories their feeling fits into. And the big one, the one we really need to understand, is true vertigo. This isn't just a vague feeling of being off. No, this is a distinct, powerful illusion of movement. When a patient says, "the room is spinning," or "I feel like I'm on a boat that's tilting back and forth," that should set off alarm bells for the vestibular system. You know, the inner ear and all its connections to the brain. Think of this table as your first big diagnostic filter. If they describe that spinning or tilting, you're heading down the vertigo path. But what if they say, "I feel like I'm going to pass out"? Well, that's presyncope. And your brain needs to immediately pivot to thinking about blood flow to the brain. Is it a heart problem? Are they getting orthostatic? On the other hand, if it's more of a feeling of being off balance, especially when they're up and walking, that's disequilibrium. Now you're thinking about issues with proprioception or maybe the cerebellum. And that last one, lightheadedness, that's often the most vague and can point you toward things like anxiety or a metabolic issue. You can see how getting this right up front saves a ton of work. Okay, so let's say your patient has true vertigo. You've confirmed that illusion of movement. You have now arrived at the single most important decision point in the entire workup. Is this problem coming from the inner ear, which we call peripheral, or is it coming from the brain itself, like the brainstem or cerebellum, which is central? And let's not mince words here. The stakes are incredibly high. The difference between a benign inner ear issue and a stroke in the back of the brain, well, that's everything. Making this distinction correctly is one of the most critical jobs you'll have. Now, this table lays out some of the key clues. Let's talk about nystagmus for a second, those involuntary eye movements. With a peripheral problem, the nystagmus is usually horizontal, and it tends to get better if the patient focuses their gaze on something. But with a central problem, you might see nystagmus that goes up and down, vertical nystagmus, and it won't stop when they focus. Hearing loss in one ear? That points strongly toward a peripheral cause. On the flip side, things like double vision, slurred speech, or weakness in an arm or leg, those are huge red flags for a central cause. So, that's the theory. But how do you actually figure this out when you've got a patient right in front of you? Well, that's where your clinician's toolkit comes in. These aren't just fancy tests. These are powerful maneuvers you can do in minutes. You have to get good at the head impulse test. It's your best friend here. When you turn the patient's head and their eyes have to make a little jump to get back to your nose, that's called a catch-up saccade. It's actually a really good sign. It points right to a peripheral problem. But here's the part that messes people up. A normal test, where the eyes stay perfectly locked on your nose, is a massive red flag in a patient who is actively having vertigo. Why? Because it tells you their inner ear reflex is working just fine. So if the reflex is intact but they're still spinning, the problem has to be somewhere else. It has to be central. And then you have these amazing maneuvers that are both diagnostic and therapeutic. You can use a test called the Dix-Hallpike to actually trigger the vertigo and see the classic nystagmus of BPVV. And then, and this is the best part, you can use a different maneuver, the Epley, to treat them right then and there on the exam table. You're literally repositioning little crystals in their inner ear. Honestly, it's one of the most satisfying things you will ever do in medicine. So now that we've got the basic framework down, let's put it to work. We're going to run through a few classic syndromes. Think of these as mental shortcuts or illness scripts that will help you recognize these patterns much, much faster. All right, first step is BPVV. This is by far the most common cause of vertigo, and the story is classic. We're talking about very short episodes of spinning, usually lasting less than a minute, and they're always triggered by a specific head movement. When your patient says, every time I roll over to my left side in bed, the room spins like crazy, you should be thinking BPVB, BPVB. Next up, vestibular neuritis. This is a completely different beast. This isn't a quick spell of dizziness. This is a sudden, severe, constant vertigo that goes on for days. These patients are often incredibly nauseous and feel terrible. But the key is, it's just vertigo. There's no hearing loss, no weakness, no other weird neurologic stuff. And this is exactly where your physical exam, especially that head impulse test, becomes absolutely critical for ruling out a stroke. And finally, let's touch on Meniere's disease. The way to recognize this one is to look for the classic triad of symptoms. Patients get these attacks of vertigo that last from minutes to hours, but at the same time, they get hearing loss that comes and goes, ringing in the ears, tinnitus, and a feeling of fullness or pressure in that ear. When you see those things happening together in episodes, you have to think about Meniere's. So let's pull this all together. It starts with a patient saying one vague word, dizzy, but now you know what to do. You have the tools. You get them to describe the feeling, you figure out if it's central or peripheral, and you use your exam skills to nail the diagnosis. You've taken a chaotic situation and turned it into a clear, logical investigation. Because in the end, it really does boil down to this question, doesn't it? Is what you're seeing a benign, easily treatable inner ear issue, or is it a neurological emergency? That is a high-stakes decision. But with this kind of systematic approach, you are so much better equipped to find the right answer.